Active surveillance is a relatively new concept. It's been around for a couple of decades now. And what it means is that you do imaging for one reason or another, and you find a small kidney mass in a patient that is completely incidental. And then you decide for a variety of reasons that you just want to observe that patient and not do surgery or do an intervention. And the term active surveillance essentially implies that you're actively following the patient. You're not looking for symptoms. You're actively bringing the patient back to your clinic, doing imaging on a every 3 to 12 month basis to see how that mass is looking. Is it growing? Does it look infiltrative or aggressive? And based on that, you can make decisions with the patient whether it's a good time to intervene or to keep observing. In general, the decision, at least in the US, is made in the urology clinic with the patient, of course. There's a shared decision-making process happening. The reason is when we say active surveillance, we're talking about small renal masses. So we're talking about masses under 3 or 4 centimeters in general. And these are patients that, at least in the US, are exclusively seen in the urology departments. Now, if there is an extremely complicated case, of course, we would bring that patient with a small mass to the tumor board or a multidisciplinary conference. But in general, it's something that we work with directly with the patient in the urology clinic. And that's and just one option. Some people might decide they don't want active surveillance for one reason or another, although they medically qualify for it. And again, it's a conversation. It's not just a statement that you tell the patient you have to do it. Of course not. It's offered as an option and explained why it's a good option to do it. And of course, ultimately, it's the patient's decision with the guidance of the urologist. I mean, most people, when they come to clinic, they expect you to schedule surgery as soon as you see them. But it's our job as urologists to educate our patients about the literature, what's out there. We know for small renal masses, the chance of this mass spreading over the next 2 to 3 years is generally under 1 or 2% if we just observe it. And most patients don't know that, or they haven't really kind of understood the concept of surveillance. So it's our job to take the time to tell the patient about their mass, about what the expected natural history is, and what active surveillance means to them. And most of the time, we can actually talk the patient into watching it rather than intervening by giving them the data, by comforting them, because the chance of this causing problems in the near future is generally very, very low. Now, some patients still, after we've done all the explanations and talking, they still want something to be done because of anxiety or because they're going to lose their insurance or whatnot. And for those patients, interventions can still be done if they're indicated to start with. So again, surveillance is one option for small renal masses in well-selected patients. It's not for everybody, but is an option that we offer to a lot of patients with these small masses.